Reactive Training Systems.
Kasper with the RTS podcast. I am joined today with Dr. Nathan Dailey and Nathan Baxter, two experts on pain and rehabilitation and getting athletes back to the bar and lifting the weight they felt before. The reason for this episode is I wanted to go through the journey of injury inception to the recovery stage and what that looks like in the journey in between. Both of these gentlemen have extensive experience in both the process, the rehabilitation, and the mental and physical struggles. And I will pass it on to Dr. Nathan Dailey to introduce himself.
Hi, Mel. Thanks for having me on today. I'm Dr. Nathan Dailey. I've been doing this being physical therapy for about 10 years now, coming up on my anniversary in August, and graduated from the Army Baylor Physical Therapy School in 2016. Served on active duty in the U.S. Army until 2020, serving in a deployed environment, soldiers, service members, family members, dependents, children, all of that in a variety of different settings, both in garrison and deployed. And then also got out and began to work a lot more with people over the age of 65, Medicare population, and then developed a real niche within the treatment of older adults. And then during that whole time, continued to treat injured lifters, and then eventually reached out to RTS in 2022, late 2022, and began a partnership with them in 2023, and have been working exclusively with RTS for powerlifters since then.
Oh, wow. That's way cooler than me. Nathan Baxter, I'm not a physical therapist. I have to, and I make sure I put all this out there. I'm not a doctor. I'm not giving medical advice. I'm not giving rehab advice ever. I am a trainer. I'm a strength coach. I just happen to have this very interesting educational background of physiotherapy here in WA in the 90s, which was my original training. I left that because I was much more interested in what was going on inside people's heads and how people develop emotions and handle those sort of things. And it wasn't until my own injury journey that I kind of came back to that physiotherapy realm, investigating the neuroscience of pain and going deep in sort of that realm and trying to look at pain a little bit more creatively than what we probably do in medical schools, and trying to understand the neuroscience and the mechanisms of what is something very, very complex, but something also really just very normal for human experience.
Very cool.
Very
I can't wait to start talking about the different pain models and mechanisms. We won't do that today on this podcast, but off air we should do that, Nathan.
Yeah,
that's awesome.
I think that's a private conversation that most people like.
Yeah,
I have conversations
people,
like that all the time, and my wife rolls her eyes and just says, "Do that in private." I'm like, okay, then.
Well, let's talk about it. We gotta work in the pain pie at some point into this conversation. The three distinct pain types and their relative contributions to the pain experience. But we can sneak it in a little bit.
Sure,
we can sneak it in.
Sounds good.
We could probably touch it in on the first part of the pain experience and the injury experience, which is usually the event or the lead up of, as a coach, you get the text message from an athlete, "Hey, I think I just did something." Their back, their hip, and one of the things that happens is, was it a lead up? Was it too much too soon? Was it too much too long? And is the athlete experiencing pain, or were they experiencing pain and ignoring it? And were they pushing through something? So as part of the discussion, framing when an athlete hits that injury, what things could they have clued into to lead up, inclusive of pain or fatigue mechanisms, in your opinion?
I'll go my really simple one-liner, and then I'll let Dr. Nathan riff off this. Anytime somebody calls me and says, "Hey, I've got pain. I did an ouchie boo-boo," the first question is, what happened? And then the second question is, what happened before what happened? And that what happened before what happened is normally 99% of the story of why they're experiencing pain now.
I would say that I'm in agreement with that. I always want to find out the history, what happened in the lead up to this, but I want to understand. So I want to understand the symptoms, and I won't bore you with how I set up a subjective exam for physical therapy, but I want to know the location of the symptoms. I want to know their behavior. And that clues me in. I mean, in school, we were taught that, 80 to 85% of the clinical diagnostic accuracy for condition comes from a really thorough subjective examination. So just talking to the patient and understanding what happened gives you a very, very good clue as to what diagnosis is most appropriate, or at least the list of top candidate diagnoses. But yeah, in my experience, it's almost always something in the lead up. I really like Jeff Alberts from Team 3DMJ years ago. He talk about the pennies depositing into the bank, and the recovery side and the stress side, and the balance between those two sides. And there's usually a mismatch at some point. If we think about a ramp in training load, and training load can be defined via, and I've talked about this before on the podcast, but these arbitrary units, which are comprised of an internal load and an external load. So how hard it feels to the athlete is the internal load. The external load is objectively the weight on the bar, like the miles run, or whatever they've done. And together, those account for a certain unit of stress for the athlete. But it's that intimate relationship between the RPE, or the difficulty of what they've done, and the absolute quantity of what they've done, however you choose to define that. Usually we've seen a unwise or increase in the training load leading up to the injury, usually exceeding, 30, 40% of what they had done as a rolling average of the weeks preceding that. Or we see a mismatch in the recovery side. So training has stayed steady, or they've attempted to really maintain their training load at the same level, but their sleep has gone down, has become more poor. The stressors in their life, their allostatic load has gone up. So as a result, in some ways you could say maybe their training load has gone up because everything that they're doing is contributing to how hard their training now feels. So the internal load of the training has gone up significantly, and they have not accommodated that by dropping the absolute load, or the external load on their bodies. So yes, there's usually a mismatch between the recovery side and the stress side that leads to the injury. And then we can get into a lot more of the specifics about how an accurate diagnosis is actually made. Because a lot of the times it's like, and you'll I'm sure be aware of this, Nathan, just pain in one location doesn't mean that pain is coming from that location, or that specific tissue is being overloaded.
Yeah, the ouchie bit can be very misleading. Very misleading. I think one of the biggest mind blowers I had when I was going through school was pain doesn't necessarily mean tissue damage, and tissue damage doesn't necessarily mean pain. And pain in a location could mean tissue damage just about anywhere else in the system, and can be just about anything. Instantly my mind goes to about 1 million different stories of people coming in and going, "Oh, my knee hurts," and go, "Yeah, okay, so it turns out it's an ankle issue," or "Oh, my back's hurting," and go, "Oh, so it's a knee," or a wrist injury is actually a shoulder injury, or elbow pain is thoracic injury. What was the saying? He who treats the site of pain is lost.
It's a lot like the elephant analogy.
Yeah.
You zoom in with this myopic viewfinder on the one area of pain and symptoms, and you fail to zoom outward and look at the other areas. And it's not the woo-woo-y, hand-wavy. It's all connected, man. I'm telling you, your thoracic spine extension, lack of range of motion is totally accounting for your big toe dorsiflexion limitation. That's why you can't bend that big toe back. I mean, I really, really, really loathe that approach to PT. But in an intelligent way, with a mechanism involved, with a potentially like a referred pain, we can definitely go down that path a little bit more, Mel, if you want to talk about that later.
I mostly wanted to come back to the athlete's experience of this when they're going through, and they might feel, say, like a 2 or 1 out of 10 on the pain scale. And that threshold of it gets better the next day, especially leading up to the meet, doesn't happen. And athletes have a hard time speaking up in the lead up, because they themselves are going to brush it off, because all the athletes that are competing, all the athletes that take their training seriously, they're going to have a certain tenacity that'll help them get through difficult things, and difficult things can sometimes mean pain they perhaps shouldn't ignore.
Ooh, I'm going to give that one to you, Doc.
So you're saying, Mel, I want to understand this. In the lead up to a meet, they're feeling some 2 out of 10 pain. They're saying, well, I'm used to feeling this amount of discomfort in the lead up to a meet because stress is high. I'm ramping up my training load just before I taper into the meet. And you're saying, how do they know if they should ignore this 2 out of 10 pain or if they should treat it seriously?
Exactly.
Okay. It comes down to a few basic assessment tools. I would say, what does the pain do in response to loading? Okay, we load it. Okay, any good intelligent warm-up is going to involve, session is going to involve progressive increases in load. And as we increase load, does pain increase linearly? And most people have that threshold for, okay, something is wrong here. Something is seriously wrong, versus a person who gets 2 out of 10 pain, goes up in weight, still stays at 2 out of 10, goes up in weight again, 2 out of 10 or slightly less. And then what is the symptom behavior immediately after they've done this? They've done it. Is that pain lingering for an extended period of time? Is it not going away? Is it worsening? Now are things that were not painful to do before now painful? When I walk away from the squat bar and go to the water fountain, am I now feeling a constant aching pain in the musculature or in the area of symptoms? So, that kind of symptom behavior. But I would say generally pain that stays relatively constant, gets no worse or gets better, and doesn't linger afterward is safe to proceed with caution, with kind of yellow lights, to use that traffic analogy.
Yeah, I like the way you say that. Mine's a little bit rougher in that, like increasing pain each time with load. I think it's a no-brainer. That's obvious. Something's going on. Book an appointment, go see someone. That lingering, that 1 to 2 out of 10 pain. There's a lot of stories that we tell within powerlifting that makes this area really, really unhelpful. I know I've said before, who's ever injury-free to meet? Everyone's hurting. Those kind of things. And I don't think that's necessarily, I don't think I've been helpful with people over the years saying things like that. The flip side of that is I tell my guys, if you can breathe through the pain, if you can slow things down and the pain drops, then that's something different. And we can manage that. We can work through that, better warm-ups, workarounds. And then after the meet, you go, you know what? It's not nice to live with pain. Get that checked out. But in terms of getting ready for game day, things like that, as long as you can moderate the pain, like if you can bring it back down, then it's probably, in my books, okay to proceed. But if you can't, or if one of the instances of, for the last month, I can get it back down to a 0 every day, and go, how long does it take now? And go, now it's taking 3 days to get back down to a 0. Or now it stays at a 2. And go, okay, so there's a change in the pain scale. So yeah, that's probably what I was getting at. When there's a change in the pain scale, that's when I start taking it really seriously.
Yeah. How much of that do you find is mediated by the psychosocial factors there? Because we think about, we can talk about
everything, hey?
The entire pain experience is an output. Pain is an experience. It's this output of the brain. I get that. But we talk about different types of pain as being more centrally driven via central sensitization mechanisms. And, most of our lifters don't fit that criteria, but broad-based pains throughout the body, difficult to predict painful patterns, maybe a predisposition for catastrophizing and maladaptive beliefs about pain experience and what it means for their future, potentially even their health in the long run. But then also differentiating that kind of centrally sensitized pain from local nociceptive pain. That's I push on it, it hurts, it goes away. I push on it, it hurts, it goes away. Very much local. They can point to it. What's your experience been coaching an athlete through their varying pain experiences over time and dealing with the athlete's beliefs about their pain?
I think the belief one is huge, absolutely huge. Like pain, we can modulate, like not so much that nociceptive type of pain. That's going to hurt the same most times. But that belief about what the injury or the pain means, I think that's huge. I immediately thought of a story of I know two people that did in field sports. They did full Achilles ruptures. One, and this was back playing Aussie rules football in the Northwest. One guy was a private contractor, owned his own business. That guy was 20 out of 10, screaming pain, in tears, wanting to beat people up, throw everything around. The other guy worked for a mining company, was fully insured, knew that he would be paid for the next 6 weeks. He was all good. Pain was manageable. It was okay. It was, but it was the same injury. Should have been the exact same experience, but the experience is hugely, hugely different based on what that pain means to your prediction of the future. And so because pain is that output and pain is a negative prediction of the future, this warning sign, change the way you're moving, do something different. We don't like where this is heading. When you apply that negative connotation to what this means, this means I can't work for a month. This means I can't feed my family. This means I can't do this, or especially when it's tied to identity, I think that's when pain really skyrockets. And I think we see this with good powerlifters, like a little injury that may not even miss a meet from, but it would change their placings dramatically. And if you're the person, oh man, I always stand on the podium. I'm a first place. I'm a record holder. I do this. And you're back in 6th or 7th. That is a painful emotional experience. And we often feel that pain physically rather than in terms of psychic pain.
And I think the other thing too is it can be especially difficult for an athlete to face that identity crisis without a clear timeline for recovery.
Yeah.
So sometimes seeing the professional and getting an accurate prognosis can really help a lot. Or here, even if you can't, as a rehab professional, provide the athlete with the prognosis, like it's going to take this number of weeks. Mel, I'm getting a little bit of feedback, sorry.
For a reason.
You can at least, it's okay. You can at least set the expectation for when you meet this criteria, you're ready to go for the next step. And here's all the steps laid out. And here's what it's going to look like to get back. Because I think a lot of powerlifters are, at least we like to cultivate this in athletes, patient, right? There's years of waiting for the next PR to really break through, to really push to break through to the next level. I mean, Presser Powerlifting on YouTube had a great video about people who took a very long time to reach really elite levels of performance and started off at relatively quote, mediocre levels. But that's a really good video to check out because it gives us all, we all like to smoke the copium, right? We all like to think of ourselves as potentially waiting or the next phase. But I think because powerlifters are patient, they can start to think a lot more along the lines of when can I expect to get better? And if you can set the expectations for that, then it lowers the threat level because they can see the future out ahead of them, as opposed to this indeterminate, I'm injured forever. This means the end of my powerlifting career.
Yeah, and that tends to be the moment and acute stage of that injury where it happens and the lifter starts to really grieve that future, as you were saying, Nathan, grieve the future of I'm not going to be on the podium. And that realization, that identity challenge. And most of the time, you kind of know when it's going to be a big one. Sometimes you don't, but that athlete's mindset in the point of injury is a really rough one to navigate as a coach when you have someone who is now going to have an emotional load on top of the physical load for their decisions moving forward. And so I want to hear how you gentlemen, when that athlete's in the acute stage, both the rehab process and the mental resilience process you guys go through with the athletes.
Oh. Nathan, I'd love to hear your take on this.
Yeah, I'm trying. My mind just keeps on dotting off to memories this morning because I'm obviously back in rugby the last few years. So those acute injuries, they're massive in in rugby union. Like they really try and kill each other. That acute phase, really about slowing everything down, adding space to it, because pain always feels urgent. Pain is immediate. Pain demands an immediate response. And normally that immediate response is, how can I get away from this experience as quickly as possible? I just want to be out of it. I want to be away from here. I want to be away from the thing that caused me damage. I don't want to be sitting where I am right now in pain, feeling what I'm feeling. And unfortunately, the way out of it is through it, is to actually, and to try and get that, whether it's slow breathing, using the mindfulness tricks and present state awareness to get it down to, okay, this is where we're at. This is what happened. It's going to be okay. And then go, all right, here's the steps. If it's, I don't know, I'm thinking about a girl that did an ACL. It's, all right, we're going to stay here. The paramedics are going to come out. They're going to bring a stretcher. This is what's going to happen. And we start trying to feed as many assurances, I guess, or try to make the future and the plan very certain and very clear. So we go, okay, the next step is this, and then the next step, and then the next step. And then to get to a point then where we can actually sit down and talk through, well, what does this mean? How are you interpreting it? All those kind of things. And normally that's while the doctor is actually treating them. And my role in that one there is more to try and connect with the emotion of the moment and to help the athlete regulate their emotion and process it sooner rather than later, because we know that will change the way their immediate experience of pain, if they can reset a little bit and just go, okay, this is real. It's okay. I'm not going to die. But yeah, most of it, especially with those really big traumatic injuries, is just about slowing the pace of the world down so the athlete can feel that they're a little bit in control again.
Can I ask you, Nathan, like you have that unique opportunity to sit there while the doctor is providing treatment and then to coach the athlete through what they're feeling and thinking. What advice would you have for medical providers and how we can change how we interact with the patient, or we share information with them in a way that decreases catastrophizing or helps what you do?
Tone. Number one is tone. So I'm writing my story at the moment, and I was remembering, so my big injury obviously are the strokes, and paramedics are just the most amazingly gentle people and can tell really disturbing news, and have you smile about it and have you feel good about it. And so literally so you're a parent, so you know the tone, Nathan, that really assuring everything's okay. This is not a big deal. Oh, you've got a thing here. And it's just that really nice casual tone that the patient go, oh, okay, well, they're not alarmed. The experts aren't alarmed. So I'm safe. But if the doctors, that, what's the word? A little bit military and precise and very matter of fact, which is what doctors are very, very good at, often quite jarring and gives the impression that, oh, gee, this is serious. I should probably be in more pain now. I should feel worse. And so I think the best I've seen is just tone, just really calm, gentle tone.
That's really fascinating, because I know as coaches, sometimes you want to come off as almost authoritative in that tone. But even in the experience you're talking about, when I've had an injury, I've had a coach come up to me like, hey, I know you're bad right now. Do you want to do some bicep curls with your friends over there? It's going to be okay.
Yeah. I know from, like, as the person speaking that way, for years, I felt like it was really fake. Like I was putting it on, and because inside, like, I'm thinking about a girl that, I ran into a high school gym one day, and this girl's lower leg was at right angles to her upper leg. It was horrible. So I literally grabbed a blanket, threw the blanket over her lower body so she wasn't looking at it, sat down in between her and her leg, and just had a little chat and go, hey, guess what? It's your dad coming in the ambulance today. He's rostered on. It just happened to be a paramedic. And we're just talking like that. Inside, I'm going crazy. I'm going, holy crap.
Yeah.
Look at that leg. That's oh my gosh. But the ability to go, all right, well, I'll process that later. I'm not injured. They are. And being able to have that boundary of going, all right, well, this is how I can influence the decision. I can just calm myself down and act like this is the most normal thing in the world that you're going through right now, and that everybody goes through it, and it's just a regular Tuesday morning.
Yeah. I think it becomes a little bit, those acute injuries, and maybe Mel, I don't mean to step on your toes or accelerate us too far in the talking points today, but the chronic injuries become a little bit more difficult to deal with too sometimes for these patients when, but it requires even more of that care and attention to detail because it's become potentially part of their identity. I'm a person who gets injured. I am fragile.
Mm-hmm.
This is yet another failing of me as an athlete and my body. I will never be healthy. I will never do this. And that becomes, you have to reaffirm them, draw attention to the wins that you achieve along the way, talk to them in a way that's an ally and a friend on this journey. Yes, the person's leg who's twisted needs reassurance, but the person who also is in chronic pain or has maladaptive beliefs needs to be reinforced too.
Oh yeah. Have you looked at much of who is it? David Butler and Lorimer Moseley, a couple of pain researchers from Australia.
Oh, Lorimer,
Yeah.
yes, Lorimer, yes, Moseley, yes.
Funny guy. I love his stuff. Their book, Painful Yarns and Explain Pain, go into this in great depth, particularly about chronic pain. Pain that you carry with you is what's the word I'm looking for? It's identity changing, and it is ruinous for mental health. If you carry pain beyond a certain point, you're going to have mental health challenges. It's just hand in glove kind of stuff. But Jed, Moseley's interventions around explaining what's going on to people in chronic pain has some amazing effects on the experience of pain. Obviously, it doesn't change the source or the cause, but the experience of pain can change drastically with education.
Yeah, we can go from the acute stage to the chronic stage because that's what comes next when after an athlete's had their event and we're going into the rehab process. There's a whole smorgasbord of what that can look like for an athlete, as Dr. Nathan and Nathan Baxter, you're both saying that mental health and identity tie to I am now an injured athlete.
Oh yeah, anytime there's an I am statement, it's incredibly powerful, either negative or positive.
Yeah, I was actually going to circle back to that transition from acute to subacute and chronic. Acute is marked by this first week to 2-week period, 7 to 10 days peaking, where inflammatory markers are elevated. We have this inflammatory type dominant pain, which is painful in almost every direction, every position. It really is about resting, ensuring that the body can go through this natural healing process and that initial inflammatory response can come down. Mm-hmm. And beginning rehabilitation or aggressive rehabilitation too early in that process after a well-established acute local soft tissue injury can be disastrous. It can set the athlete up for a lot more pain. And I've made that mistake of loading people far too soon, believing that we could work through a very small range of motion. We can introduce isometrics, whatever the form of loading is. But if there's a discrete soft tissue injury, local, not referred pain, but local pain, that could really set them up for disaster. But once they transition into that subacute phase, I think this is where a very accurate clinical diagnosis becomes so important, because I've seen athletes muddle their way through rehabilitative courses for 2 years, 3 years. There's no reason they need to be in this painful state because an accurate clinical diagnosis has just not been made. The clinician takes that myopic view. It's your TFL. We need to stretch your TFL. We need to needle it. We need to stretch it. We need to build your glute medius because your knee is diving to the inside, and therefore that's putting abnormal stresses on your patella and you're developing patellofemoral pain. And all of these diagnoses, which are not helpful for the athlete, and even give them this long list of pathologies that becomes part of their identity. I'm a person with patella alta, God damn it. I have a high kneecap. You don't understand. I have an osteochondral defect of 2 millimeters in my medial femoral condyle. And it just becomes this thing that they carry. It's a bigger and bigger suitcase and a luggage that they carry around with you, and they dump on you when you come and sit and talk to them. So not helpful, but yeah, we can get into that later.
Yeah, that's a really interesting area, that one. Yeah. I sometimes giving people details that don't, without meaning, and that's normally the problem. This is what this, so just here's all the labels. People love running around with labels because it's fun. It's going, oh, this makes me unique. I've got one of these. I'm special now, so I should be in pain. And now I'm identifying with the pain, and now the pain's mine because I've got a special thing. And so now you're really attached emotionally to that pain, and it makes treatment for the professional that much harder because there's now resistance, because now a rehab professional has to come in and say, well, that doesn't really matter so much. We work around this, we do this. It's just a starting point. People fall in love with that starting point because the starting point gives them that sense of feeling special, that they've got something uniquely wrong with them that no one else has. And then the rehab professional comes in and goes, well, a lot of people have this, and we're going to get rid of it now. And you're like, oh, but I like feeling special. So I'm sure there's a subset of the population that will stay chronically injured because they've built an identity around it, and it's now become safer for them to exist in the world with that injury, and they've got a nice label to explain it, so it's reassuring, and it stops them from doing a lot of stuff, but it also stops them from taking risks, of being embarrassed, of being in hard to deal with situations. So I think some of those labels really require a lot of explanation about what that means in reality and what it doesn't mean.
We also have very driven and optimistic powerlifters who, on the other hand, really, really, really want to set their next PR too.
Yeah.
But so they're carrying an identity. I can't set my next PR because I have a grade 1 spondylolisthesis in my low back. When my vertebrae slipped, I can't possibly do that. I just don't do that because I've had this bad experience, because I've been in pain every time I've tried this, because a person told me I have this and therefore I can't do this. A person with authority who told them that.
Right.
So that's the war. Maybe in general population, you get people who are willing to give up most forms of physical activity and cling to the identity. But that's not the majority of the powerlifters. It's this war now. It's a war between wanting to get better desperately and then being told that they can't by maybe a well-meaning medical professional, but one who's pathologizing their symptoms.
Yes. Yeah. Fully agree with that one.
So sometimes the way through that is to go down the show me route. Talk is cheap. And there's a lot of people who think they can explain to a person why they shouldn't be in pain. The classic is the new grad, right? Who read Explain Pain and sits down within their first year and says, let me educate you on pain science, young Padawan. I will ensure that you are no longer in pain by explaining the mechanisms of pain to you. And the person, it doesn't work out well. Flash to the yeah, we're done. But to be able to make a good diagnosis as a clinician and then show a person that they can do something with less pain, even if it's just like a 2-point reduction, and you don't have to tell them they're in less pain, and they feel that that sense of agency is improving, and you've demonstrated to them that they can do more. Oh, that's a powerful lesson.
Right.
Start with the position of curiosity. If the patient is asking you, wait, why did I feel so good doing that? Like what? Then they'll come back for more. They'll ask you why.
Yeah, I had one of my mentors called it the writing reflex, as in correct. Like any time, and it's especially prevalent with clinicians under the age of 30, I've found. As soon as you throw out any information, they just want to tell you what the right answer is. Oh yeah, it's this, bang, 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 bang. I think the better clinicians, like you saying here, you leave that space to go, all right, well, let's have a look. Let's see what happens. As you said, show me. And then when the people have that space to move into, they can change their mind, and it's not threatening to change their mind at that point. What was the word that you used? Agency. Giving agency back, because we do tend to, as coaches and clinicians, we do tend to steal it without realizing it, or people give it up without knowing they're giving it up. And so I think handing it back and go, well, okay, there's options. Let's explore that. My favorite one is, well, what happens if you just slow that down by half? Or can you slow that down by half again? And it's like, oh, it doesn't hurt when I do it like this. You go, well, okay, we've got a starting place now.
And that experimentation phase is so valuable as the person comes to me as the clinician, because they say, okay, I've tried this and I've tried this and I've modified the range of motion, I've modified the load, and I use safety bar squats and only depends at the middle height and it's this height. Like, okay, well, no, well, yeah. but they know what their body can and can't do, because that's a person who's experimented. Yep. And that's a person who's very aware of their limitations. So when you make a change in those limitations in some way, it's powerful for them. They're like, oh man, I wasn't able to do this in a long time, and now I can. So I would rather have the person go through that experimentation phase and learn something about their pain behavior than a person who shuts down completely, goes to see the nearest spine surgeon and says, when's my surgical date?
Yeah. Active versus passive modalities, right? We love the passive. Passive's fun. It takes responsibility off us. We go, come on, fix me. But the active, we know active is always going to be better. Always.
When I have athletes, or if I have the chance to catch them at their gym and they've just kind of had something happen, and it's usually a tweak, like a muscle tweak or sprain, like just do something else. Just do one other thing, interrupt the thoughts, and then reestablish yourself. You're still an athlete. You can still experiment and wiggle around. That usually involves them walking and stretching, grabbing things, going around ranges of motion. Then you ask those questions like, oh, when you grabbed the weight, was it kind of iffy? Like, oh no, I can still do that. And it builds that success of like that interruption of the identity phrase that I am this becomes, oh, I have this, but I am still an athlete. And that really helps with the fear of the future of like, okay, that injury that just happened isn't going to take me out of the gym, isn't going to do X, Y, Z. And they become their own agents again. Like, okay, I am here. What can I do?
Do you find, Mel, that educating person on like strength loss timelines helps at all? Like, there's a lot of beliefs for some people that they're going to lose all their strength in a short period of time as a result of a tweak. If I don't complete this session as written on paper, my strength will be gone by tomorrow, or by the latest at the end of this week. Yeah.
Thankfully, I tend to stay in my lane. I don't know how long an injury is going to last. I can't promise athletes, it's going to be 3 weeks. I do like what Mike and John said. A lot can happen in a week. A lot can change in a few weeks, and many things can change in a few years. I do emphasize the average powerlifting timeline and average powerlifter's life is such a small blip in the few months of injuries they will accumulate that those won't matter. I do bring up athletes who have gone, one of the recent ones, and this is horizontally to another sport. Maddie Rogers was an American weightlifter, full year and a half off everything. She had to work through so much, and then she's back at Prehab.
There you go.
And
oh, wow.
The journey of the athlete and reminding them that success cases that you will have PRs on the other side of this. It just really sucks in this moment. And you have to know and believe that past this moment is going to happen. Buy into a hopeful future.
Yeah. Yeah, it's tough, isn't it? That's a really tricky situation to navigate. Like, I'm thinking about injuries I had in my early 20s playing rugby, and guys who are my age now would tell me, oh, in 10 years, you will have had 3 more injuries. And by the time you're 50, we've done this and this and this. And you'll be able to look back and you'll see how it's all kind of smoothed out over the journey, that it didn't take you out. You always came back and all that. But as a 22-year-old, I'm not going to believe the 50-year-old guy telling me that. It just doesn't seem real. The real experience feels like this is the end. This is the absolute end. Nothing good can happen past this day. The world will now be slightly darker for the rest of time. Somebody's dimmed the lights on my life. So I think I bring that up because I've played with that catastrophizing with young athletes a lot. Like, you just go with them. It's going, okay, let's imagine how bad it can be really, and I'll help you out. And so there's always something in there that I will say, like, oh, the universe is slightly colder. It's going to be 1 degree colder for the rest of your life. Oh, that's bullshit, coach. That's never going to happen. I go, oh, okay. Well, now we're buying into a different conversation.
Okay, so there's the line.
And they start talking for themselves about, well, now it's actually like this. And so it's just a different way to get the athlete to speak positively about their future, like you're talking about. See beyond it.
Yeah.
Hey, if Ronnie Coleman was a powerlifting coach, he might have said, everybody wants to build custom training programs, but nobody's got a process for how to do it on the regular. But we do. You see, most coaches rely on trial and error, and that's fine if that's your jam, but we wanted a coherent process. Way back in 2015, when I'd already been coaching for over a decade, I finally had learned enough from enough sources that I was able to put the pieces together into one coherent process. We call it emerging strategies. The bulk of our 16 world record-setting powerlifters set those records using an emerging strategies program. We talk about emerging strategies a ton on this podcast and everywhere. If you ever want a single thorough explanation for how to implement the emerging strategies process, well, that's the emerging strategies course. The emerging strategies course includes 8 modules. That's almost 24 hours of video instruction covering everything. We teach fundamental concepts and basics all the way through integrated examples and case studies. You can watch it at your own pace, as fast or as slow as you want. Oh, and you know the RTS community, our private community that offers you just a stupendous amount of value all on its own? Well, if you enroll in the Emerging Strategies course, you get 6 months of that community membership for free. If you have any questions about some concept, you just post it in the network or jump on a live office hour call with one of our RTS coaches and you get your answer. If you'd like to enroll or just learn more, to include seeing a full lesson list, all you have to do is go to reactivetrainingsystems.com and click on courses in the main menu. You're going to love it.
I think also social media has been kind of a double-edged sword, because when on the same side, you see all these people who've made these amazing recoveries. And then on the other side, if you're the athlete who's injured, it sucks to watch your friend's PR and you're on the tempo Bulgarian train.
Yeah.
Yep. I think that, expectation of like timeline it really comes down to the severity and the type of injury. And, maybe I don't hang out in enough really like screamy West Side circles, but I haven't seen too many traumatic injuries in the lifters that I've treated. Maybe they're all self-selected. They're coming to me for chronic injuries. But, I think as a whole, powerlifting has a pretty low injury rate, right? Per hour participation hours overall.
Yeah. Yep.
And generally the people who come to me are coming to me with chronic or lingering issues that don't completely take them out of the gym, but limit their top end in some way. And those require a very specific, differential diagnosis process. Like, where is this symptom actually coming from? What bucket does this person fit into best diagnostically, understanding that there are overlapping buckets and we can move between buckets, but what explains their current situation right now? Because those straightforward soft tissue acute injuries that you, Nathan, have seen a lot of in contact sports, they have a more predictable, we're going to go through, it's going to get black and blue, it's going to swell up massively, then the swelling is going to come down, and then the range of motion improves, and from the range of motion, we start to load in the soft and injured tissues in accordance with their abilities, and we progress from there into more, dynamic or power-based or plyometric movements, and it follows this nice ladder progression with some setbacks. But if a person is in chronic pain and the pain is not what they think it is, it doesn't follow that pattern. It's all over the place. It's typically happens with squatting and deadlifting in a certain range of motion, but it's not always there. And it doesn't completely limit them from training. That can be even more frustrating for the athlete because they can't understand the symptom behavior. And potentially they've been to 2 or 3 other clinicians who have maybe made a very specific clinical diagnosis, and they've tried something and it hasn't worked, and they've moved on to the next one. And they don't think this can get better.
Yep. Yeah, so then we circle back to that chronic pain experience again. Like you said, like with a full ACL rupture, except for the first week, I think most athletes respond better with those massive injuries, because you go, like, we have the conversation, all right, for the next week or so, your knee is going to be the size of your head. You're going to see all the colors of the rainbow come out. You're going to experience this. You're probably going to see some gravitational edema, and there's going to be 2 days this week where your ankle feels weirdly swollen, but you haven't done anything to your ankle. Don't worry about it. And you can set them up and then go, all right, we're going to work on this for a month, and then by week 6 we're going to be doing this, and 12 weeks in this. That's highly predictable, and it actually feels a lot more like powerlifting. Through my career, working with a hip that needed surgery for about 5 years and it being misdiagnosed frequently, that pain experience is just always having this feeling of urgency of, is this it? Is this it? Is this next thing going to win? Am I going to be out of this ever? Not knowing you're going to be out of pain is crippling. Knowing that you're going to be out of pain in 12 months or, post hip replacement, knowing that in 12 months time, I'm going to be able to put a bar on my back, I'm going to squat again, was really reassuring. Being in chronic pain for years and not knowing and always believing, well, in 12 months, I'm probably still going to have this because it's been with me for so long. It's a really different set of circumstances to deal with an athlete.
It's like this minimal acceptable threshold of misery. Like, it's not so bad that I'm out of the gym, but it's also a cloud over my gym experience. And it's right at that threshold where you accept it, but it's not good.
Yeah, it's almost like
I think,
like training tinnitus.
Yes. I think the thing that always gives me a lot of optimism for these athletes is, as long as there's a somewhat predictable mechanical response, or at least positional based response. I hurt here, not always, but typically above this threshold or with this particular portion of the range of motion. And it hurts in 1 or 2 or 3 very interconnected places, but I can see a pattern here. That person has a much better prognosis in the long term than the person who has developed a centrally sensitized nervous system, where the gates of the spinal cord are just any soft tissue stimulus, mechanical stimulus is registered as threat, as pain, the body shuts down, you're in this cocoon-like protective state. That's a person who needs a significant interplay between cognitive behavioral therapy or your particular therapy of choice, and then also guided motor imagery, potentially even visualizing the joint moving through the range of motion has been shown to reorganize cortical patterns there and improve the ability to down-regulate pain response. But the good news is, like, I see powerlifters as being in this wonderful space of actually having developed a lot of agency, having trained their bodies, knowing their bodies, having a very predictable pain level, and then just needing to be shown the direction they need to head in and criteria for success.
It was really great. I actually wanted to expand on, like, for those athletes and for you, Nathan, what triggered the change of, like, okay, I need to change this? Because obviously you said you had surgery, so you were with this for 5 years in this chronic on pain, but what was the thing that cued you to escalate to the next step? Because there's a lot of athletes that meet where you're at right now and haven't taken that. Yeah.
So I had some really funny, some of the things that you were saying, Doc, about what clinicians will tell you to do. I had, so for the hip pain and the knee pain, I went in one day and they said, you need to do VMO re-education. So it just flexed my left quad. And I go, do you think it's big enough already? Because, like, it's 175 kilos. My quads were huge. Do you really think it's that? And then the next physiotherapist that I saw about my hip, it was back in the days of gluteal amnesia was the big buzz term. And he goes,
they're asleep.
And so I stood up out of my chair for him and pointed to my ass and said, does that look asleep to you? But we sort of, just funny stories.
Have you seen the baked goods I'm carrying?
Like, does this look like it's not doing work right now? Like, I just squatted 400
Popeye's
kilos
cake, you know, and I'm
in pain, but it's working.
My
right?
my knees also didn't touch one another when I reached the bottom. There's nothing wrong with that, but still, yeah, you were able to keep your knees relatively tracking forward. That means your gluteus mediuses or medii are working okay.
Right. So the thing that actually tipped me off, put me over the edge, was surviving the strokes. So because I was in heart failure for quite a long time before I had the strokes, and then stroke rehab and being in hospital for quite some time, I had about 6 months of my life where I had zero hip pain, like none, just disappeared, which is a great evidence for the way we have a hierarchy for pain. Like whatever's going to kill you first, that's what we focus on. My hip wasn't going to kill me. My heart and my brain were going to kill me. So that's what we focused on. As I started coming out, as my heart health improved and I started going through neuro rehab for the stroke, my hip pain came back. Started hurting like hell again. And I'm like, and so that's when doctors started listening a little bit closer. And it was the first time I ever got imaging done. So it was the being able to say to somebody, yeah, the pain went away, but now it's come back, but I haven't done anything. And that's when it was like, okay, there's something there. Something masked the pain for a little while. And it turns out all it was masking the pain was a much more immediate threat. And so that's why I jumped on board. Obviously that was 10 years ago now. So in the last 10 years, I tell athletes, if it doesn't feel right and you don't feel right and you don't like it, get the imaging. Just don't take the story, take the picture. So for me, it was that massive turnaround that, you know, a stroke can actually hide a hip that needs replacing.
What were the findings of imaging, if I could ask? What did that radiologist impression section say?
So it only needed X-ray. Funnily enough, there was a whole lot of, you could see the amount of osteophyte growth around the acetabulum, which explained why my hip clicked. It wasn't just like a little bit of tendon snapping. I was actually chipping bits of bone off my hip every time I moved. And there was a 90% reduction in cartilage on both articular surfaces. It was it was really, really obvious. But because I'd lived in the country for a long time before that, where access to testing and imaging was a little bit harder to do, would have involved a few $1,000s and a couple of airfares for me to get that done. It just never happened. And I got very good at moderating pain and being able to reduce my subjective pain levels. But I wasn't ever doing anything about the tissue health. I was just learning to not feel pain. And so I think really high level athletes are very good at this. And especially once it didn't help that I was a neuroscientist as well and knew the mechanism for mentally reducing my pain and not experiencing it so much. So it was, I just realized how much damage you can do by just trying to reduce the pain and not actually figure out what's going on. I'll send you a picture. I did get, my surgeon liked the head of the femur so much that he preserved it. He kept it. He took some photos of it. So I have it on my phone. I'll send it to you.
I thought you were going to show me like a what's in the box scenario. Like it was like a polymer box clear with your head.
I asked
the head of your femur.
I wanted it.
Amazing.
It looks like it was an absolute horror show. Absolute horror show. But I felt
you can
like
probably get it 3D printed.
Oh, I couldn't I? I did feel like a winner because he said, Nathan, I've done this operation 20,000 times now, and that's by far the worst hip I've ever seen. It's like, yeah, number one. His
identity rearing its your ugly head again, right. Man.
Yeah, that's the drive.
Yeah,
you can't get away from it.
No.
If you had, I think you were a self-coach at this time, right? Nathan, if you had a coach, how would you have communicated, or like if you were now the coach of a Nathan Baxter and you're walking them through this person who's very good at hiding pain,
yeah,
and you're also working alongside a physiotherapist, how are you working through this? Because you were quite good at mitigating that pain to get to the end result of training more.
Yeah. Actually, you said I wasn't. I was mostly self-coached at that time. I think I worked with Mike for about 18 months in there. I don't think I told him once. So that was 2012. And I was definitely in pain. I was in pain from 2008. So how would I do it as a coach? I would have probably gone back to the original mechanism of injury and just said to them, no, that's not right. When I look back on my experience of it, I was far too compliant with doctors and just would nod a lot, go, oh, okay, I guess so. And so a lot of me being able to modulate pain was because I thought I was being weak. So like, oh, the doctor said it's not that bad. This person says this. They're probably right. I'll just be the really ultra compliant, super helpful athlete, and I'll do my drills and I won't complain and I won't tell anyone. So, but knowing that the mechanism of injury was me slipping on a bit of carpet in the warm-up room that still had talc on it, and that I went down with 300 kilos on my back, that should have been the indicator that there's probably something going on in there. You need to address that, and that definitely needs imaging. As I live in Australia and we have a lot of free imaging, I'm a nut for just going, go get the scan. Just go get it. Just, our insurance covers it. Go have a look. Find out, and if you think you're wrong, find out that you're wrong. You could be wrong, and it might be that there's nothing wrong in there and you just, you got to work through it. But at least find out. Put something objective on it.
Can I ask you a very leading question, Nathan, that might take us off track?
Of course.
Did you have the other hip imaged as well?
No.
Okay, so go ahead. Ask it. I asked it anyway. It was a rhetorical question, Nathan. I'm just going to ask it anyway. Okay, go ahead. So tell me, did you have the other hip imaged?
No, I didn't. No.
Wonder what it would have shown.
Oh, who knows? Like that left hip is pain-free. So, we follow around and we go, oh, well, there's no pain, don't image. And I got trapped in that cycle a lot for the right hip. I go, well, there's no pain at the moment. So, but there was loss of function. There was loss of range of motion. There was the 45-minute warm-up to squat. There was 5 nights a week of foam rolling and intervention and stretching. And at some point in there, probably if I'm coaching myself, I need to go, hey, you know what? That's a bit much at the moment. There's probably something going on. If you have to do that much to get ready to train, then maybe that's the indicator that there's something going on.
It reminds me of those stories, if you've heard of Dave Tate, and how long he used to have to spend to warm up his shoulders, his hips, everything, his knees for all of his lifts.
Yeah,
he used to say that he wouldn't touch weight until the bar felt like the bar.
Yeah, so we're similar age, similar generation of powerlifting, and similar levels of stupidity, I think, because that was the culture, like that 90s and 2000s powerlifting. Everybody would get together and tell stories about how that was absolutely normal. And it's almost the goal of powerlifting to be so beat up that you need to spend half an hour warming up to get something done, because you are so hardcore. And to be honest, I liked that feeling of, well, I'm the hardcore one. Everyone else is the issue. They need to push like me. And that's where I think, Mel, you said social media is a double-edged sword. I think that's where social media has been incredibly positive and just going, guys, that behavior is just dumb. Let's get beyond it.
And the person who succeeds is ultimately the person who lives for the longest, potentially, doesn't wear themselves out in the short term or injure themselves through a whole bunch of training volume or load.
Yeah, I see all these Masters 3 and Masters 4 lifters now and just go, yeah, probably should have listened to you when I had the chance. Because, like you said, they're winning. They're still lifting in their 70s or 60s or whenever. And I think people like Dave Tate and myself bought into that idea that you have to be a world champion by the end of the year or else you're failing. you're not there quick enough.
You mentioned, and I still see it a little bit in my circles, is I have to do XYZ after a workout, before a workout, and it's because my physio gave me these things and I never want to be injured again, so I'm going to continue to do these things forevermore for every single training session. What are your thoughts on those?
I'll let you take that one, Doc.
What are you talking? I mean, I would say that I think that the list can become, never ending. And it starts in, obviously, some PT clinics will give you your printout of home exercises, the HEP, home exercise plan. And it's about, 2 pages or 3 pages, and it's got 5 exercises on it. And it's to be done 3 times a day.
Mm-hmm.
And that's it. And so let's say that the patient gets better. So then they they identify with those 5 lists of exercises. Well, I don't know which one, so it had to be all of them, and I can't let go of any of them. It's like the bodybuilder who fears to do the 1 extra session of concentration curls because he thinks his bicep is going to shrink in a short period of time. But yeah, I mean, it happens, right? So I think that what you need to do is, as a person, you probably need to, as an athlete, you need to start subtracting elements of your warm up systematically, or your prehab exercises, and see what the difference is to your training session. I was that person who spent 30 minutes in my mid-20s, late 20s, and I was foam rolling, I was doing all these quadruped, and I was doing the fire hydrants, and I was doing the cars and everything else, and I was doing everything Kelly Starrett recommended in supple leopard, and I was like flossing my joints, and I was doing everything else, and I thought, okay, this is just what I need to do to stay injury-free. And then I think as a function of time and military commitments and then family commitments, and didn't have the time anymore. And then I just started to warm up. And then I said, oh, I feel about the same. Actually, I feel pretty good. I'm good to go. And that's just continued ever since for almost 10 years. So I think subtracting things from your workout, from your prehab routine, and seeing which one is actually making a difference can be really powerful, but it takes that systematic approach. Or better yet, see a PT who gives you one thing to try at a time and see if it makes a difference.
If you can find a PT that'll give you one thing at a time, keep that PT, save them, take them out to dinner on the regular, just to have them in your circle of friends, because that's a rare individual that knows what they're doing. I fear the PTs that give that list of 12 exercises, normally in a little glossy magazine, and just says, here you go, do all of these. Meeting a clinician that will say, all right, we're going to do this one thing, and we're going to do this one thing really well, and we're going to see what happens. If it's working, you're going to feel this straight away. You're going to feel this at the end of the workout. At the end of the week, you're going to feel like this if it's working. And if it's not working, you'll experience this symptoms. And so that way we've got this really quick feedback loop that in a week or a workout, you go, all right, that's probably not your thing. Let's find your thing. And then we just keep on working
Nathan,
through it sequentially.
There's a physio.
Yeah.
There's a physio out of Australia, the late great Jeffrey Maitland.
Yeah.
Who hails from Australia. I mean, the whole Maitland model is built on test, treat, retest. Yep. So if you can empower the patient on day 1 to go home with their tests, to test and Melissa, you've been the recipient of this for me as well, but like, they have their tests. They know what their functional baseline is going to be, what their mechanical baseline is going to be, and they're going to test it. And they're going to know if those are getting better, that this is working. I mean, we can reduce the pain. That's the most obvious. If your pain is dropping in response to what you're doing, you've got resting baseline level of pain, great. What you're doing is working. If you start to gain range of motion in these positions, you go, oh my gosh, I'm onto something here. If you start to do the thing you care about, and you could do it with more weight through greater range of motion with less pain, man, now you're cooking.
Yep.
And then you have buy-in from the patient. But you have to give them those ways of assessing whether it's working or not. So you as a patient need to receive a structure and a schema for assessing the effectiveness of your PT. It's not just because I said so as the PT. It better be working. Otherwise, why are we going to continue it? It's like, oh my God, I can stretch a person's internal rotation till the cows come home. But if they can't squat pain-free, why should they keep doing it?
Right. Yeah.
That was potent. Yeah. what's that authority figure too, that we are, as you were saying, Nathan Baxter, like we strip some of our autonomy and authority to a trusted professional, and screening that trusted professional, like there's a assumption of trust that this person cares, is capable, and can help me. But the methods and means are so varied, and the beliefs can really influence what a practitioner uses as well. And I really like that grounded approach, Doctor, about like test it, evaluate it against the thing I want to do. Not success in the test itself, but the outcome is what matters.
Yeah, that I'm so glad you brought up Maitland, because that was drummed into us like from day dot. Assess, reassess, assess, reassess, and make sure you're assessing the thing that actually matters. Because like the early career trap is, but now they've got 53 degrees of motion in there and they can do this, and I'm going, cool, they can't.
That's right.
That's a field sport athlete that can't run. Don't care. Like the goal is to run pain free, not just to have a better number on a test.
Listen, I always swing for the fences, man. I always swing for the fences, and there are, it's like the addict. You're always looking for your next fix. There are some cases where just a small fix unlocks everything, from pain to mechanics to function in one fell swoop. And oh my God, you've hit the jackpot. Yeah. But as long as you've laid out the connection between a reduction in pain and improvement in this specific range of motion, and then a improvement in function, it might not happen on day one, but don't kick the can down the road, or don't accept that a PT is going to kick the can down the road and say, well, it just takes time, wait a little bit longer, but they're not giving you criteria as to what to look for. That's unacceptable. But there can be some times when that improvement in, for example, like hip flexion range of motion indicates that potentially we're about to see an improvement in something else. Yeah. But you better see that improvement pretty quickly to keep the athlete bought in.
Yeah, I think, like, I know my practice really changed when I started telling people when, like, giving them a timeline. If this is working, we should know by, and put an X. If it's not working, these are the next 3 things that we will try together. And so even then, there's always this backup plan, and the athlete goes, oh, I can really trust this person. They're not going to give up on me. For reference, I'm normally picking up the people that have seen 5 or 6 clinicians first, and they've just got that weird thing. And I'm like, all right, we'll just keep going. We'll keep on working until we'll find it. My mentor told me years ago, Nathan, you don't need to be right as long as you're persistent. So, I don't need to guess the right answer, how you're going to feel on Saturday. I can just go, oh, let's try it. And if you still feel this way on Saturday, then on Saturday, we're going to try this. And then if you still feel like that, we'll try this next. And we'll keep on running it through until we find that thing.
But those are a series of educated decisions that you're making. Maybe they're partial guesses, but they're based on a wide breadth of experience with a variety of injured athletes. And you've seen the patterns. You have a good type 1 or type 2 reasoning. Oh, someone's going to be shouting, listening to the podcast. But in any case, pattern recognition, I think it's type 2. I think it's this quick gestalt of the situation.
You know what's terrible?
Accumulate that.
I've got Kahneman on the shelf just down near my right hand. I should know that.
Fast and slow thinking. Yeah, I know. But in any case, you get better at that. So yes, I think it's important that you very much educate them on the possibility. Here are the array of options. We're going to pursue this until this doesn't work, and we're going to try this. But I do have a plan here. This is what we're going to try to pursue. And as long as that there's a person to navigate those hurdles as they come, I think that can provide a lot of relief and reassurance to the athlete.
Yeah, totally agreed.
And as we get to, say, the end of the injury, I want to touch on this before this ends, but there's a whole mental journey of approaching the weights the athlete was touching when they got the injury. That fear for some athletes, or even on the other side, eagerness. Like, I want to take on the weight that took me out. How do you guys navigate the expectations athletes have, both in supporting on risk taking, because there's no such thing as zero risk, but giving them caps or guidelines to work through?
Yeah, that's a really good question. What do you think, Doc?
I like the idea, and this almost plays more to, I think, your experience, but the series of wins that prove to the athlete or the athlete's body, rather, that they're capable. So it's having worked through the stages of rehabilitation, and then having introduced a stress that looks enough like training to the athlete, that the athlete says, I am capable of training, and you do it again, and you accumulate another win until the identity of I'm scared of this weight, or I'm scared of this level of effort. Because hopefully, I mean, at this point, the injury has lasted for a little while, and that effort is a lower absolute weight potentially than what they started with, but they understand the feeling of effort under load, even though they're not back to their prior performance. So working them back to that level of effort, and then doing it again in a controlled way, and having them check in with their bodies, not perseverate on their pain experience, but just check in, just make sure, okay, everything feels good, we're good. And then accumulate those series of wins can prove to the athlete's mind, but they're also their body, that they're capable and resilient. I don't know, what has your experience been, though?
Yeah, my first thought is always fear deconditioning. And so that's, multiple low-level
exposure,
multiple low-level threat exposures like you've just described. Like, let's break down whatever that is, and let's give you positive experience of being successful with that movement. Build it up like a Lego kit, with just one piece at a time, and then, let's try this. How does that feel? The flip side of it mentally, and we've all talked about agency and autonomy a few times here, is telling the person, it's all right if you never do it. You don't have to do this. I've seen the biggest changes with athletes going, oh, yeah, like I really don't. If I never squat this weight, I'm okay. It's not, when I'm not curing cancer, I'm not sending rocket ships to Mars or anything like that. Taking some of that, and it's weird because we're all so passionate about the squat, bench, and deadlift that we're like, oh yeah, of course they're the most important things in life. Of course I have to get that right. And to be able to look at it, mock it a little bit, play the jester with it and go, you know what, it's a bench press. It's, really, let's put it in where it belongs in life. And then take it back and go, yes, but it is important to me. It's not important objectively, but I like it. And I think when athletes view it that way, the relationship to the outcome is totally different. Because when it's outcome based, it's very painful and it's very risky because I don't know what the outcome is going to be yet. When I go, oh no, I'm going to do it because I like it. It's important to me. It's part of my values. It's somewhat autotelic to do. It's good in and of itself. I think that's the juicy bit for me.
That tunnel vision of when you're in the rehab, the goal is to get better and go back to it. And I really like the idea of, oh no, the goal is happy, healthy life fulfilled. The bench can be part of that, but that's up to you. That shift matters.
And that shift is hard. It's a lot of work to make that shift.
Yeah, I mean, you have to envision your life as continuing on potentially without this very narrow identity and what you've come to define it as. We talk about, actually, I was just listening, this is not a plug for a different podcast, but the Art of Lifting podcast. And I was listening to someone, who was it? It'll come to me, Joe Stanek being interviewed, and he was talking about, injury and identity, and trying to make sure that there are other interests outside of the gym. I was chatting with a really high-level athlete as well, and he believes that his competitive advantage is that he's going to school and he has a part-time job and he's got hobbies and interests and friends outside of powerlifting. And his biggest competitor is kind of all in, the closest thing to a professional you can get. So, I mean, I think developing that multifaceted identity outside of powerlifting can really help too.
Yeah, I think that's probably just a good rule for life, isn't it? It's just the markers of a healthy, happy individual. How often have you noticed that because we really do love the person that stands on top of the podium. How, in your experience, how many people that you met that's constantly standing at number one are all in on powerlifting, and powerlifting is their only thing? I know for me, more often than not, when I chat to them, they're like, "Oh yeah, I love crocheting, I love painting, I'm really into abstract painting or something bizarre or weird." But they've got this other passion that you go, "Sorry, what? I thought you were all about this." And like, "Oh no, I love improv comedy." You know.
Yes.
Yeah.
So maybe a little bit of the outside looking in, judging them and thinking that they're the meathead.
Yeah.
And not appreciating that they do have an identity outside of the sport. Yeah.
But then from within the sport, we see the person at the top and they go, "Oh, well, they must be doing it like this. I need to get rid of my hobbies. I need to get rid of the distractions, and I need to focus everything on being the best."
Every minute not spent
SBD
thinking
6 times a week.
about
That's right.
lifting is a wasted minute of my life.
Right? Yeah. Yeah.
I won't reveal to the listeners, I asked you about 6 times a week squatting. I'm just fascinated. I need to learn.
I really liked it. I loved the part of my life where I woke up in the morning, did weightlifting and squatting, then went and did powerlifting the latter part of the day. It was fun, but it was a few different sports, and there was also just different social groups and friends, and we would go out and do other things right after. It was also like mid-20s.
There's that strong social component to it too. Yeah.
All right. I think that brings us to our natural conclusion, that journey of the athlete. Do you gentlemen have some departing wisdom for athletes that might be listening to this, that might be in one part of that rehab journey? Not to put you on the spot to come up with something really deep on the fly, but it'd be appreciated if you guys could dredge that up.
My deep on the fly one is, I already got, pain is an action signal to do something differently. And that's
and
something.
He delivers.
Just something.
I would say be that annoying person, question everything as you're told, especially from the medical field, and don't be happy with because I said so. Ask for the proof, ask for the actual relief of symptoms, and ask for a diagnostic explanation. And don't rely too heavily potentially on a diagnosis or a pathology.
I'll leave in which time is relative, but the time spent in the middle of the injury feels like the longest time in the entire world. But it'll pass. It too shall pass.
Yeah.
Great, Mel. Thanks for having us on today.
Shh. There is a secret to great training programs, but it's not a magic set and rep scheme or this one weird exercise that powerlifting pros don't want you to know about. The secret is in your training log. You see, years ago, we began developing tools to help you unlock these secrets, and we've been putting them online for free ever since. That's right, it's free for everybody. Now you may be thinking, what's the big deal? People have been logging training forever, and you're right, but the secret isn't just in keeping a logbook. It's using that log to make better training decisions. That's the real secret. This is where the RTS training log excels. You haven't done SSB squats in 3 months and you're wondering what your target weight should be? We can help you with that. Did you overshoot on your top set and you're wondering if you should adjust your back off sets? We can help you with that too. Are you building the most important training block of this year and you're wondering what your most highly effective blocks have in common? Yep, we got you covered there too. There's more, there's a lot more. And yes, it is all free. Not just a free trial, not free with ads, just regular free. You go to reactivetrainingsystems.com, then you click on apps, sign up for a login, and you're in.